શું કોની વાત કરે છે તું? તે એ કોણ એડ થાય છે? કોઈ એક્સટર્નલ યુઝર આમાં નહીં એડ કરવાનો, એને ખાલી લાઈવ સ્ટ્રીમમાં જ એડ કરવાનો. તારી ગૂગલ મીટ કોડ એને ના આપીશ, હું અહીંથી રિજેક્ટ મારી દઈશ. મેં તને જે લિંક મોકલી ને એ લિંક ખાલી જોવા માટે, તારી લિંક ના શેર કરીશ કોઈને. નહીતર અહીંયાથી બધા બહુ જોડાઈ જશે તો આખો કોન્ફરન્સ બગડી જશે. ના ના ના, એ નહીં થાય. અને સ્ક્રીનશોટ રેકોર્ડિંગ ચાલે છે. હા, એને ત્યાંથી મ્યુટ કરેલું છે, એને મ્યુટ કરેલું છે લેપટોપમાંથી. મારે ત્યાંથી નથી, મારે ત્યાંથી મ્યુટ નથી, એને ત્યાંથી મ્યુટ છે. હું કશું ના કરી શકું. હા, એ ત્યાંથી મ્યુટ કરેલું છે ને. હા, નથી અહીંયા જો ને, આ બતાવે તું નથી. તારું બી મ્યુટ બતાવે છે. તું ઓન કર તારામાં. હા તો તું ઓન કર. હા તો તું ઓન કર. તો એવું એને કહી દે કે જો મેં ઓન કર્યું મારું ઓન દેખાશે, તમારે ત્યાંથી જશે. સ્ટ્રીમિંગ ઓફ ના થાય, ચાલુ જ રહે. બંધ થઈ જશે પ્રોગ્રામ આખો.
હેલો સર, તેમાં માઇક્રોફોન છે ને, એમાં રેડ કલર આવે છે કે વ્હાઈટ આવે છે? પેનલ જોઈન કરો ને ત્યારે માઇક્રોફોન ઓફ કર દો, ઓન કર દો. હા, એક કામ કરો, જોઈન નાવમાં કરો પહેલા.
હવે બરાબર સંભળાય મને, તમારો સંભળાય છે આમાં.
યસ યસ યસ, બસ હવે જોઈન નાવ કરી દો. એટલે પ્રેઝન્ટનો ઓપ્શન આવશે તમારે.
Present now. Okay, your entire screen. Okay. So this. Okay. હવે દેખાય બી છે, સંભળાય બી છે.
યસ યસ.
ઓકે.
દેખાતું નથી પણ સંભળાય છે.
દેખાતું નથી.
સ્ક્રીન
હા,
દેખાશે,
બસ હવે
સ્ક્રીન દેખાશે, વિડિયો સાઈડમાં આવશે.
ઓકે ફાઈન સર, તમને કહો એટલે પછી તમે સ્ટાર્ટ.
યસ, નાઉ યુ કેન સ્ટાર્ટ.
2 મિનિટ 5 મિનિટ સુધારો, આપણે 9 ને 5 મિનિટ સ્ટાર્ટ કરીએ.
હા, કઈ વાત નથી સર. ઓકે, શ્યોર.
હા બોલો. બોલ, લેપટોપ માંથી કરો.
લેપટોપમાંથી. ઓકે ઓકે.
હા.
સર લોગિન જે આવે છે તેનો પાસવર્ડ બરાબર નથી બતાવતા.
પાસવર્ડ વેબિનાર 1 2 3 4 એ પાસવર્ડ.
ઓકે ઓકે
એ મેં લિંક મોકલી છે બધાને.
ઓકે ઓકે, થેન્ક યુ સર.
morning, everyone. Usually, my talk is interactive. Probably with this website, I'm not sure. We'll not be able to interact with each other. But still, I'll try to make it as live as possible. This is my team. We have 13 physiotherapists with us and surgeons team. Today, I'm going to speak about spine anatomy and X-ray, MRI reading, panel assessment. So we start with basic anatomy. Usually, spine assessment has four aspects. One is history taking, second is examination, third is observation, and fourth is investigation. And this is how, with all four, we reach to the diagnosis. With the history taking, examination, and observation that are easily available on books. So probably if we'll get time for second time, then we will discuss about that three things. Today we'll be sharing about X-ray and MRI reading and how to investigate, what investigation should be prescribed, because it is not that easily available. Second thing, as a physiotherapist, being a physiotherapist is usually and practically all the time difficult to read X-rays and MRI. So I just want you all to get exposed to that X-ray and MRI reading. So we start with basic anatomy, which will help us to read X-ray and MRI, how to read it. So the first, we'll discuss about why do we have cows. Normally, as a physiotherapist, we focus more on the cows. Uh, Cervical lordosis, dorsal kyphosis, lumbar lordosis. This has to be there. If it is not there, what happens? There is an equation in engineering. R is equals to n square plus 1, where R stands for the load bearing capacity and N stands for the number of cows. So if you have good number of cows, so consider you have 3 cows, cervical, dorsal, and lumbar, where the sacrum is non-weight bearing area because it is floating. So considering 3 cows, 3 square plus 1, so 9 plus 1 is raised to 10. So your load bearing capacity will be 10 times more than the flat spine. So that is how the cows are beneficial to us, and that is why as a physiotherapist we try to focus more on maintaining the good cows. Second thing about the MRI, when you read the MRI, this is the axial cut of the vertebra and how you see on MRI. So this is the front part, which is vertebral body. This second to the vertebral body is pedicle. Third one is transverse processes, and this is lamina, and this is spinous process. So usually there is always difficult, to differentiate between the pedicle and lamina. So remember that after the body, the pedicle comes, and after the pedicle, the lamina comes. So first is the pedicle, and the second is the lamina. So on MRI, you will see the cut like this, axial cut like this, and this is a main central canal of the spinal column. This is a sagittal view of the vertebra, where you can see the vertebral body. Now this is pedicle because it comes first. Second is superior articular surface. From lateral view, this is the superior articular surface, and this is the inferior articular surface. The imaginary line between this superior and inferior articular surface is called as pars interarticularis. So this is pars interarticularis. So normally what happens? This is the inferior articular surface, and this is the superior articular surface. They unite with each other from this joint, which is facet joint. So this is how the lateral foramina is formed between two vertebrae. And the blue one is a transverse process, and the one going down is a spinous process. So this was the lumbar vertebra, and now this is the cervical vertebra. Cervical vertebra looks like this on MRI. On axial cut it looks like this. So this is the vertebral body in the front. On the side you can see this two tubercle. It's called as uncinate process, which forms oncovertebral joint, and which can be cause of the lateral canal stenosis because of the OA over here, osteoarthritis over here. It can reduce the canal diameter, foraminal diameter, and that can compress the nerve root, and that can have radiculopathy. This is the foraminal transverse where the vertebral artery goes up. to the brain. Behind the vertebral artery, this is a tunnel. This is called as from here the nerve root passes. This is anterior tubercle and this is a posterior tubercle. We do not see the transverse process here, but the transverse process is divided in two parts: anterior tubercle and posterior tubercle. Between that, the nerve root transmits. Now, this is facet joint again on the lateral view, rather on the posterior side. This is lamina. These are the pedicle of the cervical spine, very short and small pedicle. And these are the spinous process. Cervical vertebra, usually the spinous process are bifid. Now this is the lateral view of the cervical spine where you can see the facet joints like this. Okay. These are the pedicle here. Anterior tubercle, posterior tubercle. This is foramina transversarium. And here is the spinous process. The only thing to look over here is, in cervical spine, the foramina from where the nerve root exits out is oblique, like this. So to see the foramina directly on X-ray, it is usually not possible, or probably we can say very difficult to see on X-rays. So what we go for is oblique X-rays to see the foramina of cervical spine. Now here, this is the AP view of the vertebral body and vertebral column, cervical column. This is C2 dense. Remember this area. This is C1, C2 area where the facet look like this. This is C1 facet and this is C2 facet. Superior articular surface, and this is inferior articular surface of the C1. So this is how the C1 C2 facet joint is made, and this is the direction of the C1 C2 facet. So when the AP X-ray is done, usually our teeth is can be seen in the front of C1 C2. So normally to go for the X-ray to see the C1 C2, we have to have open mouth view. So open the mouth and you take X-ray, then you can see the C1 C2 area. And these are the uncentered process, as I said in the before the slide. This is uncentered process which is connecting with the above vertebra, and it is making a uncovertebral joint. If there is osteoarthritis over here, it can reduce the canal diameter or foraminal diameter. Now typical vertebra is made up of mainly two columns. One is the anterior column, posterior column. There is, if you divide it in particularly, there are three columns. Anterior column, which is made up of anterior ligaments and half of the anterior body. Posterior column, which is made up, rather middle column, which is made up of the posterior part of the body, and the posterior column, that is last column, third column, that is made up of the arch. So anteriorly, there is one major pillar, which is disc, intervertebral disc, and posteriorly there are two minor pillars, are facet joints. No, usually like this. If the facet joints unites with each other, it makes a single two parallel to each other on the posterior side. And anteriorly, the disc makes the first major pillar. So the anterior disc provides a static role, whereas the posterior facet joint provides the opening and closing, so dynamic role. It is made up of mainly spongy medulla inside and dense cortex outside vertebral body. Anterior part is comparatively weaker than the posterior part because posterior part can bear up to 800 kg to crush the posterior part, whereas the anterior part can be crushed with 600 kg itself. Pedicles, as I said, it is just behind the vertebral body, and they are the strongest part of the vertebral body because if you logical think, the surgeon put the screws through the pedicle. So the pedicle is the one of the strongest part in the vertebral body. Disc anatomy: the disc absorbs the water at night, and morning the height is more, 2 centimeter more in the morning. Gross, full spinal height, if you say. So evening, when you measure your height before sleep and you measure your height in the morning, you'll have a 2 centimeter of difference just because it disc absorbs the water, so it inflates, it dilates, and it increases your height. And disc is made up of nucleus pulposus inside, is not usually lied centrally. It is usually lied at the posterior part, 30 to 50% of the disc, and more toward the posterior part than the central part. So this is another thing to understand. There are two terminology. One is called as spinal segments, spinal cord segment, and one is called as nerve root. So the spinal segments are structure from where the nerve root originates. We consider as +1 for cervical, +2 for upper dorsal, +3 for the lower dorsal. D D12 at D12 all the lumbar segments are over, and at L1 all the sacral segments are over, and the L1 L2 the cord is over. Then there are only cord equine running down. So there are the spinal segments. Whereas the nerve root which is going out of it has a different countdown. If you count C0 C1, that is occiput, and C1, the C1 nerve root exits out of C0 C1. So like that, C1 C2, the C2 exits out, C2 C3, the C3 exits out, C3 C4, C4 exits out. Same way, C5 C6 C6 C7, C7 exits out. So in cervical, the nerve root of the name below vertebra will be exiting out. So if it is C6 C7, the C7 will be exiting out. C7 T1, C8 will be exiting out. Now the sequence will be changing. So in between T1 and T2, the T1 will be exiting out, whereas T2 T3, T2 will be exiting out. So like that, cervical having a nerve root exiting out will be named according to the below vertebra. Whereas the dorsal and lumbar, if somebody asks L2, L3, which is the nerve root which exits out, it is usually L2, because according to as we counted down, C2, C3 will be having a C2 exiting out, C3, C4 will be having C3 exiting out. So this is how the nerve roots are counted, and spinal segments are different, and spinal nerve roots are different. Now, if somebody asks, if L1, L2 this prolapse happens, then what is the nerve root will be compressed. So if again in that there are two nerve roots, one is going exiting out and the one which is traversing down. So L1, L2, the L1 nerve root will be exiting out, whereas L2, L3, L4, L5 will be traversing down. So like this, you can see these are the floor of the vertebral body, where this nerve root which is exiting out will be exiting from here, whereas the traversing nerve root will be going down. So if somebody asks L1, L2 disc prolapse, then if it is central disc prolapse, it will affect all the central nerve roots. Like this, if you say C3, L3, L4, so L3 is exiting out, but L4, L5, S1, S2, everything is going down. So if this disc prolapse is somewhere here, will compress all nerve roots which is going down. And if the disc prolapse is on the lateral side, it will compress the only one nerve root which is going out. So somebody with the L3, L4 left foraminal PID will be having a dermatome specific to the disc, whereas somebody who has a central disc prolapse of L3, L4 will be having a full leg paining, because it is L3 dermatome, L4 dermatome, L5 dermatome, which is all affected. So in our clinic, we do not give more focus on assessing the dermatome level, because it usually cheats. So remember this: if it is exiting nerve root or it is traversing nerve root, according to that, the symptoms will be appearing on the patient. Now, this is another important thing. As a physiotherapist, we usually ask to know give the traction is good or not. So in PIVD, so some cases we found that pain increases. So what happens normally? If it is the disc is prolapsed below the nerve root. So what happens if it is left-sided disc? The patient will tilt to the left side, because tilting to the left side, the vertebral body and disc will be going down, and nerve root as it is floating will remain there. So it will decompress the nerve root and it will reduce the pain. So patient will feel better if the disc is axillary, if she tilts or he tilts on the left side. So same side pain with same side tilt is usually axillary disc. So the root is considered as a shoulder, arm, and the disc prolapse above the root is usually called as shoulder level disc, and the disc prolapse below the root is usually called as axillary disc. So now for the traction, if you consider one-sided pain, same side pain and same side tilt, usually they behave good to the traction, because what happens, tilting to the left side or the traction will pull the down the vertebral body and disc, so it will decompress the nerve root because it is axillary disc. So it will reduce the pain because now already decompress. But if the same thing happens with the shoulder level disc, where the nerve root, the disc prolapse is above the nerve root, if the traction is given, it will pull the shoulder down, it will pull the nerve root down with the disc, so it will increase the symptoms. So just logically, if somebody want to remember, then same side pain, same side tilt will be good to give traction, but uh, one side pain and the tilt is on the opposite side will be having increased pain with the traction. So prefer traction with the same side tilt and same side pain. The same thing will be changed for the cervical spine, because the lumbar will give the traction caudally and cervical we give the traction cranially. So both the times it will be reversed. Now same side pain and opposite side tilt will be having good relief with the cervical traction. Uh, Ligaments of the spine, anterior longitudinal ligament, which is from top to bottom, it is continuous ligament, which is anterior to the vertebral body, which can be seen on MRI. PLL, posterior longitudinal ligament, which lies just posterior to the vertebral body and anterior to the canal. So this is the posterior longitudinal ligament. OPLL means ossified posterior longitudinal ligament. This ligament get ossified and it restricts the canal, reduces the canal diameter. HPL means hypertrophied ligament, posterior longitudinal ligament. So it again reduces the canal diameter. So this can produce central canal stenosis. Now, ossified ligamentum flavum is again, this is ligamentum flavum, which is on the posterior side, which connects from lamina to lamina. It connects from lamina to lamina, so it is non-continuous ligament. Whereas ALL and PLL are continuous ligament. This is the ligamentum flavum, which is non-continuous ligament. Hypertrophy of this ligament reduces the canal diameter. I put the image upside down because on MRI the images look like this. So you can see this V-shaped structure is ligamentum flavum, which is very thick, and the ossification of this ligamentum flavum can reduce the canal diameter, increases the claudication of the leg. Also called as a yellow ligament. Now, while you can see this movement, while flexion, the canal diameter opens up. You can see this, the foraminal diameter. While bending forward, intervertebral foramina opens up, whereas bending backward, that is extension, will reduce the foraminal diameter. So certainly somebody has a lateral canal stenosis or central canal stenosis will be having symptoms aggravated with extension exercises. Then preferred is to have flexion exercises. Again, I do not say complete flexion exercises. It should not increase the pain, because going for knee to chest and going for high crunches will certainly increase the pain or maybe facet joint functioning. So just go for the gentle flexion exercises, which can reduce the claudication and increase the elasticity of the posterior structures. So on MRI, if you want to see, what you have to see is this one. This is the normal. Right side is the normal vertebral body, and left side is abnormal vertebral body. Whereas we can see the first structure which can produce the stenosis is the disc. Anterior disc or anterior osteophyte can reduce the canal diameter. On the left side, you can see this. If the facet joint like this is normal and this is the hypertrophied facet joint, it can reduce the canal foraminal diameter, which can compress the nerve root. So facet joint hypertrophy can reduce this can produce lateral canal stenosis. If there is a ligamentum flavum which is going behind is hypertrophied, can reduce the canal diameter from posterior side. So this is anterior compression, this is lateral compression, this is posterior compression. So on occasion it can happen 2 of these are present, on occasion 3 of these are present. So all together can be present. The fourth thing to observe here is the foraminal diameter here is a good one, whereas the foraminal diameter here is less. So this is called as a constitutional narrow canal. By birth, somebody has a canal which is less, or rather you can say the foramina or pedicle which is short will reduce the lateral diameter as well as the epilateral both diameter. So this is constitutional narrow canal, which is considered as a cause for the stenosis. Normally, when we bend forward, flexion this lead to the nucleus pulposus goes behind, going for extension will push the nucleus pulposus forward. So usually we say for disc prolapse, we should teach extension exercises which should push the disc anterior. But now, if you think, this is the image from Kapanji, where the normal disc behave differently and abnormal disc behaves differently. Normal disc, when you bend forward, nucleus pulposus goes back, whereas in abnormal disc, if you go backward, if you do the extension, the bulge which is outside will be converted in extrusion, which will be broken from behind, like this. If this is a cyst, if this is a disc, it will be broken and it will go for protrusion to extrusion, extrusion to sequestration. So which may increase the peripheralization symptoms. So for disc prolapse, I'll suggest if somebody has only bulge, one can go for extension exercises. But somebody has protrusion, extrusion, or sequestration, would be better to go for flexion exercises. And again, not aggressive flexion exercises, just stimulating it, the abdominal muscles. Again, this is a book, Greaves Modern Manual Therapy, which has a chapter 15, 55, McKinsey method, which has mentioned this centralization can be thought of a reversal of this process. It will only occur when the annular wall is still competent. So centralization occurs only if the annular wall is competent. If it is not intact, which is the can convert in, as I said, it can convert in extrusion, it can convert in sequestration also. So it is a reference from McKenzie's book. So we usually prefer McKenzie phenomena. That's why it was just too good to clear what to do, what not to do. So this was all about the anatomy of basic of spine. Now we'll be going for basic normal radiology, how to read a normal X-ray or a normal MRI. I would like to show you first, how the MRI is done. So this is the table, or in case a trolley on which the patient lie down. They have been instructed that you'll be having any difficulty in breathing or something inside, if you congestion, just press this bell. So this bell has been given to the patient. Now they are giving the headphone because as a magnetic resonance imaging, they have resonance which makes lot of sound, so it bothers the patient a lot. So we usually give them headphone with some FM radio or something, whatever songs they like. Now this is the MRI of brain, so they cover this head like this. So more of the patient, they have a lot of claustrophobia if somebody is head is covered like this. And now the trolley will go inside. This black thing is this white thing is a coil beneath the patient, which lies down beneath the patient, and from there the imagings are done. So as I said, spinal assessment has four parts. One is the observation, history, examination, and investigation, which we are going to talk only about this fourth one. Three of these are not easy, but it is really important, as good as this fourth one. But as a physiotherapist, we are not exposed to X-ray and MRI reading, so that's why my target was to start with the X-ray MRI first, and observation, history, and examination will be covered on next time. So before starting the radiology, the most important thing is clinico-radiological correlation. So whatever we see on MRI, it is not necessary it is the diagnosis. So MRI is not the diagnosis; it is just a clue to complete the diagnosis. Somebody sees the L4, L5 disc prolapse, and if the patient complains on the pain of only on a hip, then there is no dermatomal match. So one should always consider the clinical examination, that is history, observation, and examination should always match with the radiological correlation. So this is called as a CRC, clinical and radiological correlation. Second thing to always remember is differential diagnosis. More often what happens, as a junior, when I was fresh, when we started practice, as we started learning the MRI. When we see the patient entering the cabin, immediately from the posture, we just say that this is a PID, and the MRI rule out the Cox spine or something different. So not necessarily all the time whatever we think should be diagnosis. On occasion, you should always keep a differential diagnosis ready, that it may be this differential diagnosis. So that should be the next target or next treatment plan if they do not get the relief from the first 10 days of treatment. So we start with radiology, normal X-ray and normal MRI. So it is like, when we see this image, it look like somebody is wearing there is somebody is in a meditation and these are screaming in their ear. But now if we see properly, it is JBL speakers ad. It look like a speaker, but now because you have seen, you feel it like a speaker. But if you're not seen before, then somebody will consider that somebody is meditating and somebody is shouting in their head, on their ear. But this is a common image. Everybody knows that these are the two faces, and there is a flower vase in between. So what I just wanted to convey through these two images are whatever your brain knows, your eyes will see. If you have not seen MRI ever, then your eyes, so your brain will not be able to recognize what is it actually. So whatever I'll be teaching today will not make you completely throw off the X-ray and MRI, but will give you some idea. Whenever you will see the MRI, you will be able to judge whether it is normal or not. So this is the ABCD of X-ray. We start with the X-ray first. My choice of investigation is always X-ray because more often it is cheaper. It is cheaper. The second thing is uh, more of like bony pathologies can be seen very nicely on X-rays, whereas the MRI can show only the disc pathology or nerve root or cord pathology. So A, B, C, D. The alignment is the first word to understand. A for alignment, where we draw the four lines. One is the anterior longitudinal line ALL. The second is the posterior longitudinal line PLL. The third is the facetal line, and the fourth is the spinous process line. So these all lines should be aligned properly in line. This vertebra should be in same line. So that is alignment. The second line is the last, which is this is the line, fifth line, which is usually drawn in cervical spine only, which is not drawn in lumbar because it doesn't uh, implement there. This is a line where this is a pharynx, oropharynx, and the distance between this shadow, white shadow, you can see this is a trachea going down. So oropharynx, pharynx to trachea. Now, the distance from pharynx to the C1 should be at least of 5 mm. If it is oropharynx, it should be around 1 centimeter. If this distance or if this shadow is enlarged, if this uh, trachea is pushed forward, will be considered as some pathology or some collection over there, maybe abscess or maybe some other pathology. So this shadow should be having at least 1 centimeter distance, and this shadow should be having at least 5 mm distance. As I said, as we know that lungs are seen black on X-ray because it contains air. The same way, the airway or respiratory system contains the air, and that is why we see like this. So this is alignment. The second is the bone quality. So this is normal bone quality. Bone quality can be learned by experience. By looking more and more images of X-ray, we can know this is normal bone quality. C for cartilage, which includes disc, which includes the cartilage includes anterior longitudinal ligament, PLL. Hmm. It includes anterior longitudinal ligament. It includes posterior longitudinal ligament. The ossification can be seen on X-ray, so that is why one should see the C cartilage. And D for disc. Disc height should be seen on X-ray. If you see all the disc going down, should increase the height. Whereas you can see this disc height is reduced a little. So A, B, C, D. Now this is AP and lateral X-ray. We will identify the structure. This is AP view and this is lateral view. The 1 number stands for the clavicle. The 2 number stands for the cervical rib, first cervical rib. 3 number stands for vertebral body. The 4 number is for the spinous process. Fifth number is again for the spinous process, or maybe you can say trachea going down. Sixth number is oncovertebral joint uncinate process on the side. You can see this elevation on the side is uncinate process. In this one number is vertebral body. 9 is, as I said, is oropharynx. 2 number is spinous process of C7. C7 spinous process is the longest of all cervical vertebral spine. So this is 2 number, which is cervical C7 spinous process. 3 number is lamina. 4 number is inferior articular surface of the facet joint of this vertebra. And 5 number is again a superior articular surface of this vertebra. So we can consider this vertebra as a single vertebra. And now if you see this one, so this is inferior articular surface from this to lamina to spinous process, again going up with this superior articular surface, then again going down with the vertebral body. So this is how the vertebral body, single vertebral body can be seen on X-ray. 6 number is C2. Again, it has a big spinous process. 7 number is dense. This is the dense. 8 number is anterior arch of C1 because C1 doesn't have body. It is only the arch. It looks like this. So the anterior part is the arch, can be seen anteriorly. AP view, I have just put it just to show you, this is the spinous uncovertebral joint. This is how it is made here, and which can be seen nicely over here on both the sides. So this is uncovertebral joint, and this is uncinate process, which can be seen only on cervical spine. As I said, this is anterior tubercle anteriorly, and this is the posterior tubercle where the nerve root goes out from here. Now this is oblique view. As I said, that the foramina on the cervical spine are little oblique, so one should be having oblique view to look at the foramina. So here is oblique view where you can see these are the foramina. 3 number is the foramina, 1, 2, 3, and 4. So these 4 are the foramina. But this one is the pedicle. Pedicle can be seen like this on oblique X-ray. These are the pedicle. Mainly, it is used to see the oblique X-rays are used to see the foramina. And this is how the oblique X-rays are done of cervical spine. The patient is made to stand on the oblique side with the X-ray. This is the receiving plate, and this is the emitting area. From this, the X-rays are emitted. This is upper cervical spine. As I said, C1, C2, open mouth view, where you can see this is dense. This is a facet joint, C1, C2 facet joint, like this on both the sides. So C1, C2 open mouth view, where you can see the facet joints on both the sides. This is foramina transversarium, where the vertebral artery goes up on both the sides. Inferior articular surface of C1 and a superior articular surface of C2. So this is open mouth view. Somebody who comes with the only one complaint with the cervical rotation restricted, they have only one complaint that they cannot rotate the cervical spine truly and it is painful. Only cervical spine rotation, not the flexion, extension, anything else. Except the rotation is not possible. They will be like stiff neck. So that they are the indication of the cervical C1, C2 open mouth view. One should go for that. Normal lumbar spine X-ray looks like this, where one can see the spinous process is aligned with each other on a single line, where this oblique part, these are the facet joint. You can see this one. These are the facet joint. This is another facet joint, both the sides. It looks like an owl. You can see these two are eyes. Pedicles are eyes. One here and one here. You can see these are two are eyes, both the sides. This one is the eye and this one is the eye. And this one is a big charge. This is the face of the vertebral body. But these are the eyes are pedicle. This is spinous process. You can see the ears on the sides are transverse process. The one vertebral body goes like this. So this is vertebral body, and for that the posterior arch is this one going down to here to here. This all area is of the same vertebral body. The vertebral body lies above and the arch lies below like this. Okay, and this is facet joint. You can see the psoas muscle starting from L1, L2 to going down. This is the shadow of the psoas. You can see nicely psoas muscle. Somebody who has a cox spine or psoas abscess will be having absence of this shadow over here. These are the gas in the colon. ઘણા પેશન્ટ પૂછે કે આ શું છે પેટમાં કેમ કાળું કાળું દેખાય છે કેન્સર થયું છે. This is normal, it is gas which looks like black shadow. These are the SI joint. As it is oblique, it has multiple lines. You can see this line, you can see this line. So this is the SI joint in all together. So this is the SI joint. This is hip femoral acetabular joint and pubis symphysis or oblique foraminal obturator foramen. Normally, whenever we advise AP X-ray, should be advising AP with hips and SI, because hips and SI doesn't charge extra, but we can differentially diagnose the hip from the spine in the same X-ray. If you write only AP X-ray, the X-ray technician will do only AP spine. They will not include the X-ray of hip joint. So if you prescribe the X-ray AP with hips and SI, they will include both hips and SI together. So you will be having same patient will be having a benefit of cost. Now, this is the X-ray and this is the MRI image. I'm going to show you what, this is L2 vertebral body, this is L3 vertebral body. L2 has an inferior articular surface here and L3 has a superior articular surface over here. So when we take a axial cut of this image over here, so it will show like, the anterior part is the part of the same vertebral body. So if somebody asks that, if the anterior, this is a part which is of a below vertebral body. So if the image is taken consider this image has been taken from here. So this one is L4 disc, and the anterior part is made up of L5. So you can see this is the L5 articular process, and this is L4 articular process, and this is the lamina of L4 above vertebra, and this is the nerve root which is exiting out. You can see this one is the nerve root, black one. This is L4 nerve root which is exiting out, and lateral foramina over here, and this is canal where you can see this is a facet joint. We'll show you in detail next slides. This is again lateral X-ray with dynamic movement, X-ray flexion extension. Usually, what we do, we teach exercise according to X-rays. So somebody has a flexion extension X-ray available. One can really see the X-ray whether the instability occurs on extension or on flexion. So according to that, also one can teach exercises. This is how the X-rays are taken. Flexion extension X-rays are taken. So it is quite painful because somebody has to stand for a long time on extension movement. So it is usually painful. So before advising dynamic X-ray, one should see whether the patient is comfortable to go for X-ray or not. MRI has 3 cuts. Now we go for MRI. X-ray is over. So MRI has 3 cuts. One is the coronal cut. The second is the sagittal cut, and this is the axial cut. So sagittal cut is this one. Coronal cut is this one, and axial cut, the last one, is this one. So MRI is done like, I'll tell you the process what happens actually in MRI. The body is made up of water. The water contains H2O, so hydrogen and oxygen. Hydrogen has 1 electron. As you remember the chart, H1, He2, Le3, Be4, B5, C6. Carbon has 6 electrons. Same way, hydrogen has 1 electron, 1 proton, and 1 neutron. And the body goes in a magnetic tunnel, that is magnetic resonance MRI. So magnetic resonance imaging. So the body goes in a tunnel. So the electrons will be attracted toward the positive pole of the magnet. The full round tunnel is magnet. The full round tunnel is magnet. The body goes in a magnetic tunnel. The electrons are attracted towards the positive pole, and the protons are attracted towards the negative pole. Now the resonance is passed. So there is a sound. And once you attend the MRI center, you can see a really big noise. And that stimulates the electron, which passes from one orbit to another orbit. So electron gets activated and H becomes H plus. So electron goes on a next orbit. It releases the energy. It emits the energy, which is absorbed in the coil, which is beneath the patient, and that is called as T1W. That is time 1 weighted image. Okay, so this is T1W, time 1 weighted image, and where the electron settles down again. So that is T2W, time 2 weighted image. The fat suppressed image is again made up from a basic image taken on MRI. They suppresses the fat. Scanogram, they say scanogram. So that from the scanogram they suppresses the fat and they only highlights the water. So that is fat suppressed image. Now why to learn this T1, T2 and fat suppress? Normally, more often it is very easy to read from T2, and this is T2. You can see nicely the disc. You can see the vertebral body. You can see the roots and cord ending over here. It is easy to predict T2. So the first of all, the choice will be of T2. If there is a doubt of infection, one should be seeing T1, even fat suppress also, or any edema or inflammation. So how this T1, T2 and fat suppress helps? So T2 is very basic image, which is very easy to diagnose. Now after that, T2 has 2 things which is bright. T2 has water, which is bright. So wherever is the water, if it is CSF, if it is disc, they all are bright. And the fat is bright. So this is the fat, subcutaneous fat, which is bright. So water and fat are bright on T2. And on T1, we have only water, which is only fat, which is bright, and water becomes black. So T2 has 2 things bright, water and fat. So wherever the water has to be, it has to be. But then there are places where the water should not be there. Like if it is disc, yes, one is agree to have water. If it is canal, one should have water. If somebody has bladder, it is expected to have water. If somebody sees the kidney should be having water as it contains urine. Now, if it is vertebral body, the water in vertebral body is usually a sign of inflammation, edema, or infection. So now, if it is water inside vertebral body, it should be black on T1. So that is how one can diagnose if it is fat or water. If it is bright on both T2 and T1, that is fat. If it is black on T1 is water. So water in abnormal places is not accept no, it is not expected. It is not expected. So this is how one can diagnose T2 and T1. So if somebody has infection, will be having T1 as a black and T2 will be a bright. We'll show you the images on next slides. So now fat suppress again confirms if it is fat or water. So fat becomes suppressed on only water becomes highlighted. So you can see this is well hydrated disc, normal CSF fluid. This is again a good disc. This is dehydrated disc because it is black. Now how to read the MRI? MRI images usually have a one image with the cuts like this, which names 1 to 13. So now if you see the first image, second image, third image, fourth image, fifth image, sixth image, 7, 8, 9, 10, 11, 12, and 13. So total, no, you can see 12 images over here. So starting from the left side, MRI is done with the head on the opposite side. So patient's left is our right and patient's right is our left. So the image starts from the left here. So it is mentioned here. You can see this left to right. It is mentioned here. Now the first part comes is a lateral part of the body, which is which is attached with a lot of muscles and everything. So you can see the topsy-turvy over here. It is not clear picture. Now as you go centrally, you can see the foramina on the side, lateral side. This was very lateral. This was a lateral image which shows the foramina. These are the foramina, where you can see the small black dots are nerve roots. These are the nerve roots. These are the nerve roots. Now going again medially, furthermore, will show a cord in a central canal with roots going down. Again going further laterally, these are the foramina, which is big with the nerve roots inside. Again on the right side going and far lateral. So from far lateral to lateral, lateral to medial, medial to again lateral, lateral to again far lateral. So the MRI images are taken like this. Somebody has a scoliosis, will be having a real bad MRI. Will be very difficult to look at the MRI images and diagnose what it is, or maybe degenerative scoliosis, or any kind of scoliosis. Uh, this is full length screening. So when we advise MRI, we usually advise a full length screening. So if it is required, because somebody has a whole body or whole spine pain, can be seen nicely on this. Now you can see this one is arch of aorta. You can see this is arch of aorta going down. This is aorta, descending aorta, subclavian artery. These are the vertebral artery going up. You can see this nicely. And pons, or rather you get cerebellum, pons, medulla going down to become a cord. Now this is the cord. Now we can see again, you can see the cord nicely over here, but you cannot see the cord here because it is on lateral image. Or maybe the patient has some tilt of neck. So it doesn't show the cord here, it doesn't show the cord here, it doesn't show the cord here, but it shows the cord here. So actually you have to combine all images together and make it a 3D, and then you can see it properly. Now this is the axial cut again. So as I said, the single cut is given at the down side, which shows the cuts 1, 2, 3, 4, 5 to 22, and cuts are taken like this 1, 2, 3, 4, then again 6 to 10, then 10 to 15, 18, 21, 22, and they have been put from here, and they usually mention it over here on the side, slice number 1, slice number 2, which is not seen nicely on this, but then this is how the images are taken. So here the numbers are given, the numbers are always prescribed over here, or else they will prescribe the label D11, D12, D12, L1. Now you see how to recognize the structures on MRI. MRI cuts are taken, axial cuts are taken from three places. One can be taken from here, that is vertebral body, and one can see the foramina over here. One can be taken from here, vertebral body, which can show pedicle, and the third can be taken from the disc, which can be seen with the disc and the foramina behind. So disc always have nerve root behind, but vertebral body may have pedicle behind, or it may have a foramina behind. If the image has been taken from here, the body may be having a nerve root. If the image has been taken from here, it will be showing the pedicle. So now you see this. There are two intensity to be seen. One is black from outside and bright from inside. So this is nucleus pulposus and this is annulus fibrosis, which is outside. Good well-hydrated disc, normal disc. This is black. Again, it is dehydrated disc, and the gray area, which is no. This is the area with the light intensity, which is vertebral body. So good disc, dehydrated disc, and vertebral body. So now you see this is disc, again disc, vertebral body, but there is part of a disc taken from here. Now disc, again disc, vertebral body, again body. Now if you see this one, it shows the kidneys on the side because D12 L1, the kidney ends at L1 L2, and now you can see after this L2 L3, one cannot see the kidney. So L1 L2, the kidney can be seen. Now diaphragm can be seen over here nicely. You can see this one diaphragm. Now this is psoas muscle on the sides. These are the psoas muscle on the sides. Psoas muscle. It starts from L2 L3 going down, becomes big and big, but as they go down further, it goes on a periphery towards the ilium, and this is how it looks like. Initially small but near to the vertebral body, then big and near to the vertebral body, and there is a big, but then they are far from vertebral body. And the psoas sepsis can be seen over here. Now, if you see in detail, then this is a cord with a single area, and these are the nerve roots. You can see the dots; they are called equina. So these are the nerve root. But you can see these dots on the sides are exiting nerve root. These are the exiting nerve root. These are the cauda equina. Facet joint can be seen over here. This is the facet joint. This is the facet joint on both the sides. Facet joint contains water. So you can say this is the facet joint with water, whereas this is not a water contained facet joint. So maybe you can say a degenerated facet. This is ligamentum flavum. As I said, V-shaped structure is ligamentum flavum. What else can be seen? Extensor muscles. You can see the septas. These are the white, which are septas between the muscles. Contains interstitial fluid and fat. This is again a big septa. Erector spinae muscles can be seen here. So the erector spinae muscle. If somebody, there are patients who come with this area which is completely white, contains only fat, not a muscle. So they are usually called as a sarcopenia, the muscle loss, muscle atrophy. Cervical spine MRI shows cerebellum, pons, medulla, the cord going down, but then this is a little tilted neck. So one can see the CSF and you can see the cord nicely over here. So one cannot say that this cord is lost from here. Actually, it is tilted, so that's why you cannot see the cord on all slides. So here you cannot see this cord, but then you can see the cord over here going down. And these are the disc. This is dense of C2, and arch can be seen anteriorly. A small bulge you can say over here. This is what we are talking about, all normal MRI and how to read it. Always a cervical MRI is a little difficult than the lumbar vertebral MRI to read. This is the foramina transversarium where the vertebral arteries goes up, and here the nerve root goes out. This is a disc. This is vertebral body. This is body, disc, disc. Here the nerve root goes out. Here is the cord, and here is the CSF. So in cervical spine, normally know how to read the cervical axial cut, whether there is a compression or not. In single form, somebody really want to remember, then if you can see the CSF around the cord is a normal vertebral canal diameter. So you can see the CSF here, you can see the CSF here, you can see the CSF here. Everywhere you can see the CSF on all canal. But then here is a canal where you cannot see the CSF. It is only the cord. So there is moderate compression over here of the disc. Because it is a disc, it is a discogenic compression. This is dynamic MRI. Somebody has a Hermit sign positive. If looking down leads to shocking pain in upper limb and lower limb. So somebody has a compression only on flexion or extension can go for a dynamic X-ray. So if somebody says I have only pain while I'm look down or while I look up, then one can go for dynamic X-ray, MRI. You can see the compression over here at C3, C4. Another thing called as a stress MRI, where the stress MRI, what we do actually, patient lie down with the foot rest, and there is a harness which is attached to the shoulders, and the harness is tightened from here with the knob, and that will increase the pressure in the disc because it gives compression force. Somebody who has pain only while walking or only while standing, claudication only while standing or walking, and while lying down, the symptoms disappear. And the normal MRI comes negative or normal, then one can go for the stress MRI. Stress MRI is quite costlier than the normal MRI. Normal MRI costs around 4,000, whereas the stress MRI costs around 6 to 8,000. So better to go for normal MRI first. And if one can find no compression, but the specific complaints patient has, so again the clinical radiological correlation are not matching, then one can think of this stress MRI. This is spectrography, which shows the tracts, cervical tracts. Somebody has a trauma and one want to diagnose whether the patient will recover or not, or how many tracts are still intact. You can go for this spectrography. It is a costly investigation, so more often people doesn't go for it. MRI just works, or MRI serves the purpose more often. What is normal and non-symptomatic? So if you see such a big osteophyte anteriorly in the neck, but the patient doesn't have symptoms, they do not have any dysphagia or any other symptoms, then one can consider this as a normal. Somebody has osteophyte in the anterior part and have compression with significant dysphagia, one should give importance to that. Otherwise, it is normal to have this anterior osteophyte. Posterior osteophytes are more often symptomatic because it compresses the nerve root or cord. Now we can see this one. Uh, uh, this is the inferior articular surface of 5, 4, and 3 L3 vertebra, and this is the superior articular surface of L4 vertebra. So this is the facet joint, and again this is superior articular surface of L4 vertebra, and this is inferior articular surface of L4 vertebra. So this is again a pars. Here is a pars interarticularis which is intact. So this is normal. Now you can see this is L5 has a superior articular surface and inferior articular surface over here, but there is no pars here. You can see, and this is my X-ray, and I have lysis. It is common to have lysis. I'll say many patients usually appears with lysis with no symptoms. We had a study done at our center, going for an X-ray of every individual. Somebody who has lysis not necessarily have pain. So if you see such lysis on X-ray, do not say that you have fracture, you have this that. So patient will go with the fear. This usually is not that painful. If that leads to instability or that leads to listhesis, can be painful. Again, this is a disc prolapse. You can see this is X-ray. X-ray doesn't show disc, but still X-ray shows this fracture where the disc has broken this anterior part of the vertebra and it travels down and it breaks the anterior end plate. So this is anterior disc prolapse. Whereas this is a central disc prolapse, which has broken the end plate, middle end plate, and it has gone inside. So this is limbus vertebra, anterior disc prolapse. So kind of PID, types of PID has anterior disc prolapse, has central disc prolapse, and it has a posterior disc prolapse. Posterior has 4 subparts: lateral, rather central, paracentral, lateral, and foraminal, rather far lateral. So this is a part of anterior disc prolapse. This is a central disc prolapse, which is called as Schmorl's node. This is limbus vertebra. This is Schmorl's node. So they have different names: central disc prolapse, anterior disc prolapse. This is normal MRI of a spine, which shows a big cyst over here. This is called as a Tarlow's cyst, which is normal to happen. There are many people who has this cyst, which is non-symptomatic. So if you find such cyst, a watery cyst, subarachnoid cyst, you can say, which is normal. So this was all about the normal imaging. Now we switch over to the abnormal radiology. We are on time. Abnormal radiology of lumbar spine. Now you see, this is the normal disc. The normal disc structure should be concave from behind, from posterior side, and this shows the cauda equina over here, and this is the facet joint on the side. Whereas you can see this one is not a concave; it is convex. So this can be considered as a disc bulge with no major compression. There is some foraminal stenosis on the side, but only from one image one cannot comment about a stenosis. So this is just to show you that how the disc bulge looks like, and more of the disc bulge are non-symptomatic. Uh, this is protrusion, where you can see the disc has the nucleus pulposus has made a rent in a annulus fibrosis. It has come out. It is over here, but it is still contained in annulus pulposus, annulus fibrosis. So the disc prolapse has not happened completely. It is still intact with the parent disc. So this can be considered as a protrusion, whereas this was disc bulge, and this is a protrusion where it doesn't go out of the disc. It's still in contact with disc, and it is in contained material yet. This is a classic example of extrusion, where the disc material has gone out of from here to here. You can see the material outside. So this is disc extrusion, and the disc protrusion, like extrusion, has happened on the left side of L5S1 disc on the left foramina. So this is going to be a significant painful, because if it's foraminal or lateral, this is you can call it as a maybe paracentral disc prolapse, which can compress the nerve root of foramina, which can increase the significant pain. This is sequestration, where the disc has fragment has been separated from the parent disc. This image doesn't show, but then this image shows there is a separation from the disc. But again, ideally, you cannot say this is a sequestered disc, because you should be having multiple images to have a 3D image combined together, because it shows here it is intact. But here you can say this is how it looks, that the sequestered disc, separated disc from the parent disc. So we showed bulge, protrusion, extrusion, and sequestration of the disc. So this is how the MRI can be, seen. Now again, this is descending aorta. One can see over here. This is descending aorta. Again, a bulge with the diffuse bulge, a central and paracentral area. This is the central area, central zone, paracentral zone, and this is a foraminal zone, and this is extra foraminal zone. So this is again exiting the root outside. You can see this one. This is foraminal PID, the most symptomatic and most painful PID, because somebody has a foramina. The foramina itself is narrow, and the disc prolapse happens in the foramina, can compress the nerve root with significant pain and significant agony. So this is L3, L4 disc prolapse on the right side foramina. You can see this is the normal foramina on the one side, and the other side there is a disc prolapse which is compressing the nerve root. Again, you can see this one is normal disc. You can see the psoas muscle on the sides. This is normal foramina both the sides, cauda equina over here. But you can see this is normal nerve root going out, exiting out. But you can see the bulge over here. So this is extra foraminal, outside the foramina. The disc prolapse outside the foramina, which is again non-symptomatic. More often the extra foraminal disc are asymptomatic. On rare occasion, it can increase the pain. Somebody who has extrusion or sequestration like this or like this are more likely to get normal within 2 months or maybe 3 months by natural course, without we doing anything, without we interfering anything. So we may take a credit that I give this manipulation, or I give diathermy, or I give this one, and the patient got relief, or the disc disappeared. It is not that. 90% of the patient, the research says that every disease has a natural history. Like Shardi, somebody has a cold, have natural history of healing in 7 days, whether you take medicine or not. More often it resolves by itself. The same way the disc resolves by itself within 2 months or 3 months by itself. And the extrusion and sequestration has a very good prognosis compared to the protrusion and bulge. If the protrusion is painful, more often it ends up with the surgery. This is again an extrusion with a big PID which is completing a canal, occupying the full canal. So central, paracentral, you can say it is full bulge, both the sides, and more on the right side. Again, this is disc prolapse. This is called as a subligamentous disc, where this is PLL, posterior longitudinal ligament, which is going down like this. You can see this. Now this ligament has been lifted up by the disc from behind. So this is called as a subligamentous disc. Now after this, the disc may go above, may go below. On occasion, with somebody who has subligamentous disc, has a poor prognosis. They do not recover, they do not do well. So more often they need surgery. Somebody has this kind of disc prolapse, they usually require surgery. Normal disc look like this, and the dehydrated disc look like this. This is a black disc. What else I can show you over here is there is a conus medullaris. The cord has an end, which is called as conus medullaris, which contains all sacral segments and lumbar segments, end of the lumbar segments. And from there, the cauda equina, like this, the roots goes down. So this is conus medullaris. It has to end at L1, L2. No, if it is L1, L2 or maybe D12, L1, this is a little high lying cord, you can say. Now this is again a disc prolapse, which has a lateral foraminal extrusion, which has pain. Patient will be having pain on the left side, L5S1. This is normal foramina, and this is a compressive area where the nerve compression is happening. So this is again extrusion of the left side, L5S1 disc. Where you can see this is normal facet joint. This is facet joint, which is normal with a good hydrated area, and this is ligamentum flavum, V shape. This is disc, and this is body. Still, it shows this part because the disc is extruding and going upside. If the cut is taken from here, you can see the vertebral body in the front, and you can see the part of the disc migrated upward on the back side. So this is again extruded disc on the left side with migration upward. Now such disc, somebody has extruded disc, we go for contrast MRI. It says that when somebody has disc extrusion and the contrast MRI is done with the dye injected in the body, in the veins, in the arteries, and it goes to the area of neovascularization. So if the healing is taking place at the disc, it will show the bright area over here. You can see this bright area over here, this bright halo. So if this bright area is seen in place of the disc is getting a good new vascularization. So there are good chances of the disc to get resolved. So somebody who has a pain since 2 months or 3 months, but they do not want to go for surgery and they just want to confirm whether the disc will resolve or not. So one can go in that period for this contrast MRI. Contrast MRI again costs around 10,000. So it is again costly imaging. So one should not go immediately or all the time. This is a terminology, neovascularization. So new kind of vascularization of the disc, around the disc. This is called a Bartolotti syndrome, where this is the normal X-ray on the left side and this is the abnormal X-ray on the right side. Where you can see alignment, the spinous processes are okay, everything is all aligned, well aligned. You can see these are the facet joints on the sides are again normal. The same way here also, the spinous processes are also okay. The facet joints are here. You can see this is the facet joint. This is the facet joint again. This is normal on both the sides. And these are the pedicle, both the sides. So there is all pedicle present. There are all spinous processes are present. There are all transverse processes are present. But here you can see this is the transverse process of L5 on the right side because it is right side. And here the transverse process of the left side. The left side transverse process is getting attached with the SI joint, sacral of the other side. So this is called as a Bartolotti syndrome, where this gets fused and inflamed over here and can be painful. So what happens with this, abnormal biomechanics happens where this facet joint is immobilized because of this is the stagnant and this is a fixed area. And this facet joint gets more mobilized because it is free area. So more often the patient comes with the opposite side pain. In such such conditions, one can give a mild grade 1 metal mobilization, which can move this facet joint. It can nourish this facet joint. Now we start with the condition wise X-ray and MRI. So this is the listhesis 1, 2, 3, 4, 5, and S1 alpha S1 listhesis grade 2 with lysis and with a vacuum sign inside the disc. One can see the black shadow inside the disc. This doesn't contain air, but if contains air, that means it has instability. You can see this is a normal alignment over here. This is normal. Again, this is also normal, but you can see the cut over here. So that is a part of lysis. And lytic listhesis grade 2 with instability. Instability can be of three types. One can be a sliding, one can be a rotatory, and one can be a sliding with rotatory combination. Here it is more of a rotatory because you can see this end plate to this end plate there is angulation, but whereas you can see this end plate and this end plate completely get reversed on extension. Now this is a type of listhesis, degenerative listhesis, where you can see the disc has been degenerated completely, and which has led to a degeneration and listhesis. 5, 4, 3, L3, L4, L5, L4, L5. Now terminology listhesis itself, it says slipping of above vertebra on a below. So it is never a single vertebra. You cannot say that L5 is moving backward on L4. It is usually always L4 is moving on L5. L3 is moving on L4. So if you say L3 doesn't move on L4, it is on the same line. But L4 is moving on L5. So L4 is moving anteriorly on L5. So this is called as L4, L5 anterolisthesis because the above vertebra slips anteriorly. If you read the definition, it is flipping of above vertebra on a below vertebra. So according to that, you have to decide the direction. So such definition doesn't need to be proven. There are a few people who say, why don't you say this is L5 retrolisthesis on L4? It is never L5 on L4. It is always L4 on L5. So L4 L5 anterolisthesis and L5 S1 retrolisthesis. You can see this one L5 is going behind from S1. So this is L5 S1 retrolisthesis. So probably I hope I'm clear. You just follow the definition because it is a definition. Why the one has to be 1 plus 1 has to be 2? It is proven that 1 plus 1 has to be 2. So again, this is listhesis. This plastic listhesis where this pars. This is again pars. But the pars is elongated. So this plastic listhesis of L4 on L5 anterolisthesis. L4 L5 this plastic listhesis anterolisthesis. Is called as iatrogenic listhesis. During the surgery, on occasion, what happens? One can damage the facet, which leads to instability. Now we can see this is a spinous process. This is a spinous process. You can see the half of the spinous process. There is no full, it should be like a droplet, like a tear drop, but it is just shown as a half drop. The below half is not there. You can see the window over here. So there is a window over here which shows the laminectomy. So lamina with the spinous process has been removed. So this is laminectomy done. During the laminectomy, on occasion, somebody can damage the facet joint and it leads to listhesis. So L5 S1 grade 1 listhesis. So iatrogenic listhesis. This was example of iatrogenic listhesis. Now grades of listhesis. So this is a grade 1 listhesis where the above vertebra on below slips 25% of the full length of below. So this is grade 1 listhesis. So you can say this is lytic listhesis with grade 2, 25 to 50%. About more than 50% is usually grade 3. More than 75% is grade 4. You can say this is listhesis and plate over here, and more than 75% listhesis is happening over here. And a complete listhesis with subluxation is called as spondyloptosis, grade 5 listhesis. This is how it happens. If it is 100% listhesis, it is spondyloptosis. Spondyloptosis is a congenital condition. It gradually develops after the middle age, during the age of puberty, or during the full growth happens. Now again, this is listhesis. You can decide among yourself which kind of listhesis is this. This is L3, L4 enterolisthesis, L4, L5 retrolisthesis. The shadow over here, the black shadow is a flank. Tire, the tire you can see over here. So this is the flank shadow. So this is normal to see. Now this is the MRI. You can see facetal effusion over here. This is normal facet joint on the one side. Maybe dehydrated, you can say. This is dehydrated facet joint. This is degenerated facet joint, completely black. Over here also, this black facet joint, completely degenerated. Where you can see this fluid, a significant fluid inside the facet joint. So like a knee effusion happens. This is a facetal effusion, which can reduce the canal diameter and which can cause the stenosis. So here the stenosis is because of two things. One is the disc anteriorly because it is bulged, and the facet joint posteriorly. So it is also subluxating, or maybe you can say there's facetal effusion. So that is why there is a stenosis. Now this is the CT scan of the same patient, and CT scan usually seen same on the same side. So this is on the right side, facetal effusion. Here also it is on the right side facetal effusion, L4, L5, right side facetal effusion. Okay. So here the facet joint is quite good, normal with the good and facet end plate, facetal end plate, facetal disc, and here the disc and end plates are completely eroded and damaged. So you can see this is the CT scan of the same patient with facetal OA. So again, there is another patient with the facetal effusion inside the facet joint. You can see the good amount of fluid inside the facet, which shows instability, which can be considered as instability. But the thing to be seen here is a facetal cyst. Now you can see this is a facet joint, but then this is a cyst which is coming out of it, and this cyst will be symptomatic from behind. You can see this cyst is seen over here. This is a facetal cyst over here, which is from behind, which can compress the nerve root on the foramina, which is going out. Here again, you can see the compression is from both the sides, posterior and anterior. More often with the degeneration, with the patient with the old age, it is usually difficult to find a single side compression. It is usually from all the sides, anterior, posterior, side, everywhere. So this was the example of the facetal cyst. Now, if it would have been interactive session, I would have asked to diagnose this X-ray. But one can see ABC. Now we see A, B. A for alignment. Alignment is not proper over AP on AP. It is scoliotic over here. You can see this. Now the pedicles are not at the same distance to each other from here. This is a near distance, and this is a far distance. So the patient is tilted to the one side. Second thing is B. You can see this is bone quality, which is normal. Bone quality. It has to be a square vertebra over here. The same it is square vertebra over here, but then at the below, at the lower end plate, it is not square. The area which is destructed, damaged, which shows the area which is eaten away, which doesn't show there. If it is fracture, then the area will not be a destruct. No, you can say eroded. You will not see the destruction. You can see the fragments all around. You can see the complete vertebral body with fragments on the sides. But then if it is infection, you can see this kind of scalloping, a kind of eating of the bone. So this is T1 because the CSF is seen black over here. So this is T1 where you can see the vertebral body is black here. Normally the vertebral body should be like this on T1, but this is abnormal T1. So this is water inside the vertebral body. So water inside the vertebral body means infection, inflammation, or edema. This is T2 again. So as I said, T2 is more often, it is not all the time informative in such cases of infection. So you cannot see the properly, you can see this is bright area. It can be water, it can be fat because, you can see the bright area over here also. But now you see this one, this is fat suppress image where the fats are suppressed. This is coronal cut from the front, and this is a pouch of psoas abscess. You can see here. So this is cox spine. So infection usually looks bright on T2 and black on T1. Okay, so I must be clear by now. So how the infection should be. And again, bright on fat suppress. So you see this one, this image. So this is T2 because CSF is bright here, the disc is bright here, the fat is also bright here. So this is T2. You can see some area has been changed. It shows some black area over here. So now T2, this is vertebral body, which is normal, but there is some area on black. Black on T2. Okay. Now we go for T1. Again, there are area which is completely black over here. So ideally, it should be completely bright over here if it is infection. And this one, you can see this is the area which is very bright on fat suppress also. So now the difference between infection and malignancy is that one, more often the infection starts from the discal area and plate area and anterior column. And more often the malignancy starts from the posterior column. So the posterior column also get affected in if it is malignancy. The second thing, as I said, the disc is spared over here. You cannot see the disc destruction over here. There is only vertebral body which is destructed, only vertebral body which is affected. Whereas the infection, the disc is the most common culprit because a disc has a poor blood supply, doesn't have good nutrition supply, so it gets infected very easily. So infection affects the disc first, whereas the malignancy usually affects the vertebral body first. So this is the example of malignancy. This is multiple metastasis. Now you can see the difference between the infection and this is infection and this is malignancy, where you can see the posterior area is also affected on this image of malignancy or neoplasm, whereas the posterior area is spared over here. The infection has started from the disc area. Disc is completely destructed, whereas the body is completely destructed, but the disc is completely spared. So this is how you can differentiate between infection and malignancy. Now you can see this is normal MRI with psoas around, psoas muscle around, with a good facet joint, with the quad equina inside, ligament of flavum with V shape. But you can see here, this is a psoas muscle which contains a bright area. On the other side, the psoas is normal, whereas this is containing abscess. So this is fat suppress image where the psoas abscess can be seen very nicely over here. You can see this is a pouch throughout the psoas muscle. So this is an example of psoas muscle, how it looks on MRI. This is another example of MRI. How the normal MRI looks like this, with the good psoas muscle on both the sides, with the good extensor muscles like erector spinae and everything. All extensor muscles are bulky, black on color. Whereas you can see this image, you cannot see the psoas muscle on the one side. You can see the psoas muscle on the one side, but the other side doesn't show the psoas muscle. So this is atrophied psoas. It usually can be seen with the patient with the poliomyelitis. Somebody is a poliomyelitis will be having atrophy of the hip flexion or of the iliopsoas of the one side. Can be seen like this. So this is normal MRI, and you can see this is abnormal MRI. The absence of psoas. You can see some good muscle over here, but you cannot see the good muscle over here on the extensor also. So there are extensor muscle atrophy also happening on the one side. So you can treat such patients with evidence that there is a muscle atrophy on the one side. So you need to go for exercises and specifically train on the other side. Now, this is normal MRI. You can see a good canal with good CSF inside, with the discs well hydrated, with the porta equina going down. Whereas here you can see canal diameter itself is less from beginning. As I said, this is something called as a constitutional narrow canal. By birth, the canal diameter itself is less, and in that, if something happens like a small disc prolapse or a small mild hypertrophy of ligament of flavum, which can reduce the canal diameter like this. Grossly, you can see a stenotic canal from top to bottom, and you can see the maximum stenosis happening over here, L4, L5, and you are not even able to identify the structures that which is producing the stenosis. So this is called as a constitutional narrow canal. Normal canal is oval shape. The second is a heart shaped canal, which is again still it is normal. But this is called as a trefoil canal. Trefoil canal. So kind of E shape and triangular. So constitution narrow canal can produce is a part of stenosis. Stenosis is a very vague term. Stenosis means compression on the root or canal or cord, narrowing of the canal. But the factors which can produce stenosis are conditions like listhesis, like facetal cyst, like disc prolapse, or like hypertrophic ligament flavum. So these are the structures which can produce stenosis, and stenosis in general is a big term. Now we see the part of types of stenosis. This is a normal canal where you can see the chorda equina. This is a type A, which is normal, where the chorda equina are settled down at the bottom. Because when you lie down, when the patient lie down supine on MRI, the chorda equina are tended to settle down, and you can see the CSF above. Now, this is chorda equina, grade B. You can see the chorda equina all around. The chorda equina cannot be differentiated. Still, there are space between the chorda equina, but still there are all around, spread everywhere. And you can see dura mater here. This is the dura mater, and this bright area is epidural fat, which can be seen. Again, grade C, where you cannot see the chorda equina differentiated with each other. It is all together, clumped now root together. They're clumped together, but still you can see epidural fat over here. This is epidural fat, which can be seen here. With grade D means there is no chorda equina seen or differentiated from each other. There is no epidural fat can be seen. It is completely black or zero canal. We call it as a zero canal. So grade A and grade B can be treated conservatively very nicely. But grade C and grade D, where grade C can be tried with conservative treatment, but more often they ended up with the surgical treatment because it is a degenerative kind of stenosis. Whereas grade D always needs surgery. If somebody comes with you with the MRI with the grade D canal stenosis, you should not try to give a physiotherapy. It may occasionally help for maybe few days or few months, but again at the end, usually go for the surgery. And grade D stenosis can lead to chorda equina syndrome, that is affection of the bladder and bowel. So you should treat with it with very pinch of salt, very carefully. So as I say, this is grade A. It has again subtypes A1, 2, 3, 4. So chorda equina is settled down. It is spreaded around, but the central area is spared. It is spreaded down, but the above area is spared. It is spreaded down, spreaded everywhere, but still it is above and below area is spared. This is grade A. Grade B means chorda equina everywhere. Grade C means a clumped nerve root with epidural fat can be seen. And grade D means it is all complete zero canal. So here, this is again spinal X-ray, which shows this is normal on flexion, and this is extension X-ray, which shows the air inside the disc. It is called as the Knudsen sign. It is a sign of instability. Somebody has a disc, somebody has a vacuum inside the disc. It shows that disc is dehydrated because there is no water inside. So it has a vacuum inside the disc, and it is called as a Knudsen sign. It is usually sign of instability. Now you see this MRI. So this is a coronal cut where you can see bright area over here. So coronal cut with the fat suppressed. This is a fat suppressed image where you cannot see the fat anywhere. You can see only water everywhere. So this is a CSF which can be seen nicely. This is a kidney which can be seen nicely, and this is a bright area. So fat suppressed showing a bright area means there is a edema or infection. Our next image. This is T1. If it is bright area is water, it should be black on this. So it is again black over here. So it is pakka, it is water now. But if it is water, it has to be bright on this. So if it is fluid, it has to be bright on this. So again, it is black over here. So black, bright, it is not matching with our thinking or our strategy, which we decided that even black ho જોઈએ, T2 bright ho જોઈએ, and the fat suppressed should be having suppressed fat. Now, in this case, what should be considered it as a modic changes? It is a type of degeneration. It happens. Modic changes are of three types. One can see this end plate are bright in T2 and black on T1. So it looked like infection because infection is always bright on T2 and black on T1. But if it is infection, patient will be having significant pain, which even modic changes can have. But it has to have ESR or CRP or WBC counts. So now in this case, one needs blood reports. And second thing can be seen is spasm. If somebody has a real spasm, a night pain are the signs and symptoms of infection. So, as I said, CRC, clinico-radiological correlation. One seeing this MRI, one will certainly say it is infection. But when you see the patient, you will be able to differentiate between the patient the symptoms and MRI findings, and you can say it is modic changes. So this is the only way to differentiate modic changes from the infection. And for us and somebody who is just learning phase, who is reading this MRI, it is usually challenge to differentiate modic changes from infection. So before stating it as an infection, one should always go for either blood report or go for clinical evaluation. And the third thing can be done is if it is infection, it should have some abscess collection around or pouches of abscess can be seen. So that is again another thing to be seen on uh, MRI. The third thing which can be of help is X-ray in such modic changes. Modic changes will show erosion on X-ray, whereas if it is infection, it shows destruction, as I showed in that X-ray. The vertebral body was completely destructed. So this is how we can differentiate from modic changes part type 1 from the uh, infection. Now what we saw was this one, modic changes 3. Now modic changes 2 has again a bright end plates. You can see this area which is bright here in T1 also. So these are bright, and again these are also bright. So these are again modic changes type 2, which is bright on both images. Because if it is infection, it has to be black on T1, but there is no black on T1. It is bright on both places. So you can consider this as a fat, because fatty infiltration will be seen bright on both places. So this is again modic changes, bright on both area. This is again a stage of, these are the stages of degeneration. Degeneration start like this with modic changes 1, then 2, and then permanent black. So this is again, as we saw on this image, black on P1 and black on P2 also. Both are black. So this is modic changes 3. So this is again a grid of degeneration. This is stress MRI. Normal MRI, where we went for normal MRI, this was the facet joint with the effusion can be seen over here. And canal diameter was also good. You cannot see any block over here. This is myelogram. Myelogram can show only a cord. So this is why it's called as myelogram. So there is no block on myelogram. But whereas you can see this one, the diameter is reduced than this one with the stress MRI. This is a stress MRI image. This is a normal MRI image. So you can see the block over here. So when go for stress MRI, we found this block, and the facial effusion is gone over here because it is compressed. So the area will be compressed more, and the facial effusion is disappeared. This is considered as a Schumann's disease. Schumann's disease. It is a congenital kyphosis developed because of three consecutive wedge-shaped vertebra like this. This is again wedge-shaped vertebra, this is wedge-shaped vertebra, and this is wedge-shaped vertebra. Somebody will be having a steep kyphosis over here. You can see this is a steep kyphosis here. And for this only we can treat that. So with exercises and extension strengthening, interscapular strengthening, one can develop this or one can reduce this kyphosis. Now this X-ray, you can see the pattern. This is the normal X-ray. You can see this is a normal bone quality. ABC, again I said, go for ABC. So this is alignment which is normal. Bone quality is normal here. Whereas you can see the bone quality are bright on ends, and you can see the black within. That is osteoporotic area, we can say. And this is again disc. So bright black, bright black, bright black. So kind of my T-shirt. So this is called the Roger Jersey syndrome. Somebody has a kidney disease, somebody has a renal dysfunction, would be having such X-rays. So if you find such X-rays, you can pinpoint on kidney disease, or you can have a renal function test done. Abnormal bone metabolism lead to such kind of images on X-ray. Now this X-ray again has a, you can say this is normal X-ray. I have kept a normal X-ray to compare with it. So this is normal X-ray with the good bone quality, you can see, and there is lines A, B, C. Alignment is good over here. Whereas you can see alignment is okay, but then bone quality is different. This is quite bright, hazy area over here. The vertebrae are attached or fused with the anterior longitudinal ligament ossification. You can see ALL ossification over here. It is fused with each other. So one can consider this as an ankylosing spondylitis. But why not to consider this as AS? Because this is fluorosis, and fluorosis affects interosseous membrane, which ankylosing doesn't. Ankylosing doesn't affect the interosseous membrane. Interosseous membranes are present between the radius and ulna and tibia and fibula and obturator foramina. So you can see this is interosseous membrane of radial ulna. You can see this is ossified. This is interosseous membrane of obturator membrane inside the obturator foramina, which is again ossified. Ligaments are ossified. Whereas this is obturator foramina, which is very good, which is clear and normal. So this is fluorosis, and fluorosis X-rays can be seen like this. Just put in your brain that this is how the fluorosis X-rays look like: bright, with fused, and with the interosseous membrane affected. Now you see this MRI image. It has been mentioned that suggests a possibility of multicentric low-grade infection. So one can find this as an infection over here. So we call ankylosing spondylitis as a cheater. More of an MRI shows infection, which turns out to be ankylosing spondylitis on X-rays. You can see this is a SI joint which is fused completely, and you can see the bamboo spine also. So this is a patient with ankylosing spondylitis, and the MRI of the patient shows like infection. And on occasion, it happens also that somebody puts them on AKT or anti-cox treatment or kind of that treatment. So always see for SI joint over here. SI joint is like this, and you can see this area also. This is also SI joint. This is also SI joint. This is also SI joint. This is completely fused over here. So this is AS, ankylosing spondylitis. Again, anterior longitudinal ligament ossification can be seen over here, which is fused with each other. So this is called as dish because it doesn't show the SI joint affected over here. It is again, it is spared SI joint, nor the obturator phenomena is affected over here. The bone quality is as good as the normal X-ray. It doesn't show that bright, that hazy. There are few brightness seen over here because of the overlapping of ALL with the vertebral body. But the lateral X-ray, you can see this is normal intensity of the X-ray. So this is called as a dish. Diffuse, idiopathic, skeletal, hyperosteosis. Diffuse means all over the body. Idiopathic means there is no reason for that. Skeletal is a bone, and hyperosteosis means ossification, which can be seen very highly. And again, the second thing to be differentiated from the ankylosing dish is that AS will be having anterior longitudinal ligament ossified with this thickness, whereas if it is dish, more often it is like this thickness. It has very rigid and very big thickened ALL. You can see this is a facet joint on MRI. This is MRI again, and this is the facet joint on the right side, which is normal, whereas the facet joint on the left side is degenerated, but the alignment is also changed. Normally, the facetal alignment starts from cervical spine, which is more of a horizontal area, and that is why the rotation is more on cervical spine, because 50% of rotation happens at C1, C2, and the rest of the rotation happens at the lower cervical and spine. So, because of the horizontal facet, we have good rotation. Because of the coronal facet, the thoracic spine has a side bending, but because of the rib cage, it reduces. Whereas the lumbar has a facet which is quite in a sagittal plane, not completely sagittal, but quite in a sagittal plane with some obliquity. So you can say this is a normal facet joint, which is sagittal area, whereas this is completely sagittalization of the facet L4, L5. So this can be considered as a mal-aligned facet. Such facet joints can produce symptoms of pain, which can be reduced with the flexion exercises or maybe a local ultrasound or kind of some mobilization techniques. And on occasion, if it doesn't work, then we go for a root block. And at the end, if it still doesn't work, then we just remove the facet and we just fuse that segment. You can see this MRI and this MRI. This is a normal MRI. Yes, there is a disc prolapse here, but I don't want you to see the disc prolapse. I just want you to see the cauda equina or phylum, or rather conus medullaris, which is ending over here, right? And now you see this one, the cord goes down, 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 and still down, and it ends somewhere at L5 or S1, maybe coccyx, maybe S1. So this is called as a tethered cord, where the cord ends lower than the expected or the normal length. And what happens, by the time of birth, the cord and spinal segments are with the same length. As we grow up, the spinal column grows and cord grows very slowly compared to the spinal column. And that's why the cord ends at L1. But whereas what happens in uh, this patients, the cord is attached with the bony segment, and as the column grows, it will stretch the spinal cord, and patient will be having symptoms of bladder bowel, maybe symptom of radiculopathy. So such cases, on occasion, they requires a surgery. Physiotherapy has very less to do with this such tethered cord symptoms. You see this one. Um, this is a normal canal with the cauda equina clumped together. So you can say this is grade B stenosis because the cauda equina is attached. Sorry, grade C stenosis where the cauda equina is clumped, but there is epidural fat can be seen over here with the roots going out. Now the thing to be seen over here is the below vertebra. This is the vertebral body, right? This is the disc. This is the vertebral body, and you can see the septum. There is a line in between. So this is the line in between, and it is dividing the roots in two parts, one and two. This is again you can say as a this is called as a diastomatomylia. Where there is a septum inside the cord, it cuts the cord. It is inside the cord. So when the column grows, it cuts the cord because the cord is going to remain the same and the column is going to grow. So it divides the cord in two, and it can lead to symptoms of same like tethered cord, bladder bowel involvement, or radiculopathy. And such cases also require surgery in middle age. This is a X-ray which shows a bright area over here. There is actually cement, vertebroplasty cement. When surgeon introduce the cement inside the vertebral body, which is collapse, it will look like this. So this is normal to be seen on patients who are operated with the vertebroplasty. You can see there is a scoliosis over here on this side. So if you count the pedicle, you can see these are the pedicle, which is normal. You can see this triangle area. This is a hemivertebrae. The scoliosis occurs congenitally, it occurs idiopathically, but when there is congenital scoliosis, it shows such kind of hemivertebra or half vertebra, half formed vertebra. So that leads to scoliosis. And such cases can be treated with physiotherapy to if it has not reached to 40 degree of Cobb's angle. Once it reaches to 40 degree of Cobb's angle, it is usually not possible to treat them with the physiotherapy and belt and corsets. So they need surgery after the angle of 40 degree. Now you see this X-ray. There is a destruction of the vertebral body, but still you can see all the fragments all around. It is still, together. So it is a burst fracture. You can see the instability, neutral position, and flexion. Flexion it goes for unstable. This fragment which is in the front, it gets separated from the vertebral body, and this segment here is also going for separation from the vertebral body. So, which is a serious fracture. No, if the posterior column is attached, if this is the column, if this is a line which is attached and non-displaced, it is a good fracture. You can say it can be treated conservatively. And if they do not have any symptoms of lower limb and obviously. But then if somebody who has a posterior column broken like this, two parts. So, you can see this upper part and this is the lower part and displaced. They need surgery because this is not going to unite. So this was all about the abnormal radiology. Of lumbar spine. Now I'll take another 15 minutes to finish with the cervical and dorsal imaging radiology. Now this is the image of cervical instability. You can see listhesis of C3 over C4, C3, C4 enterolisthesis. Cervical spine, usually we do not use the word listhesis. We use word subluxation. We say like C3, C4 anterior subluxation of the vertebral body, and which settles down a little on extension. This one again, the image of C1, C2 subluxation. You can see the marked in yellow on left side is C2. This is C2 dense base, and this is the upper part. They are not united to each other. There are congenital condition where the C2 is not formed completely, and you can see the fragment, the C2 upper part of the dens is getting subluxated over here with C1 together. So we call it as a C1 C2 subluxation. Others you can say os odentorium. The odento process is not formed completely, so this is os odentoidium. The second image is of C1 C2, as I said, open mouth view. You can see the facet joint nicely over here, but here you can not say a good facet joint. Over here it is good, but the other side, on the right side, there is a facetal OA. So it shows the reduced space between the C1 C2, and more often the patient has rotation pain. So this is image of C1 C2 OA, the rotation, somebody who has rotation pain. Now this is oblique X-ray. As I showed in normal X-rays, you can see oblique X-rays. You can see a foramina on the side, which is nicely seen normal. Whereas on this oblique X-ray, you cannot see the foramina nice over here. See, this is the normal good foramina on the one side, and the foramina over here is narrow. No, this is a posterior file which is causing the compression. So oblique X-rays are used to find out any root compression on foramina because it is cheaper than the MRI. So you can see this is the cervical spine MRI, which is usually difficult to read for anybody. For me also, when I joined, it was easy for me to read lumbar MRI, but cervical MRI was always difficult to read. Now, what one should remember is this: as I said, you should be able to see the CSF around. You can see the CSF around. You can see the CSF around. You cannot see the CSF here on the side, and you can see there is a disc prolapse on the foramina left side. You can see the foramina over here is clear. Now this is the foramina. You see, this is the foramina going on the side. This is the foramina. This is the foramina. Everywhere it is open. This is a vertebral body, so you cannot see the foramina. You can see the pedicle over here. So this is a pedicle on the side. Whereas this is also a pedicle. This is also a pedicle. But this is a foramina on the side because it is a disc. You can see this is black. And this is a foramina which is clear. But the foramina over here on the left side is not clear. So there is a compression, disc prolapse on the left side, C566. And it can be seen. It is usually easy to see sagittal cut than the axial cut. So you can see the disc prolapse over here, which is again lifting the PLL, posterior longitudinal ligament. If you want to count the segments, then you can C2, C3, C4, C5, C6, C5, C6 disc prolapse on the left side, which is mentioned. Now, again, this is C1, C2 subluxation. You can see dents on both the sides. This is a dents, and you can see this is an anterior part of the arch, and this is a posterior part of the arch. Here it is connected with distance from each other. and here it is near to each other. You can see extension is settling the vertebral on normal pace, whereas the flexion is increasing the subluxation. You can see this. Now, you can see this arch is over here. This distance here is this one, the dense, and the C1 arch. This is the dense and C1 arch, which is compressing the spinal cord over here. You can see this, right? So this is C1, C2 compression, dislocation and compression. Dynamic MRI. If you see C1, C2 over here, you can see this is normal, good. Rather, you cannot say normal, but then this is good diameter over here, extension. So extension reduces the symptom here, and the flexion has a less diameter than the extension. You can switch over your eyes over here, from here to here. You can see the flexion is increasing the compression. So this is dynamic X-ray where it shows flexion increases the compression. You can see the block vertebra here, D1, D2. There is no disc in between, a small rudimentary disc, just for the sake of it name. This is dumbbell shaped vertebra, and more often is again non-symptomatic. But it can increase the instability above and below. This is called as ACM, Arnold Chiari malformation. Normally, what happens, this is a occipital area which cups the cerebellum. Whereas in this cases, cerebellum herniates down more than 5 millimeter. More than 5 millimeter. So if it is more than 5 millimeter, you can consider this as a cerebellar herniation. And cerebellum herniation leads to blockage of CSF flow, CSF circulation, which make a rent inside the cord, and it goes inside and produces syrinx. So CSF of the fluid inside the cord, which is called as syrinx. So this is called as a Arnold Chiari malformation with syrinx inside the cord. And they usually have symptom of cervical myelopathy, like spastic upper limb, spastic lower limb, like that, or all human symptoms. Now this one shows the fracture of D11, a wedging of D11. Rest of the vertebrae are normal with lysis of L5 S1. This one, you can see this area is very clearly seen here. So this is lysis of L5 S1. This is again fracture, but one cannot say this is wedging because it is 3-column injury. Wedging is normally 1-column injury. The anterior column is broken and wedge shape. Whereas you can see the pedicle alignment. Now you see the spinous process alignment is normal over here. This is all normal. But the pedicle here and here, here and here are okay. Here and here are okay. But here and here, there is a distance between this pedicle. Now you can see there is a cut through the posterior arch. You can see the column has been broken completely. So this is 3-column injury. And such injuries needs surgery. Whereas the only wedging can be treated very well with the conservative treatment. And on MRI, you can see the posterior structures getting edema. This is a split fracture of cervical. You can see the vertebra normally are compressed or wedge shape, but here it is split into anterior and posterior part. This is a tumor, SOL. We call it as a space occupying lesion, SOL. So such tumor can compress the nerve root or cord, and that can produce the symptoms according to where it happens actually. And this is again the case of metastasis, where you can see the T1 is black, fat suppress is bright, T2 is also black. So not matching, T1 has to be black, T2 has to be bright, and fat suppress has to be bright. So, you can see the multiple places. It is affecting normally only the vertebral bodies. You can see 1, 2, this one, this area. This is not affecting the disc. Disc is spared. So again, this is image of multiple metastasis. But as I said, this was the patient with the wrist drop, and somebody diagnosed as C5, C6 PID because there was a nerve root compression. That's what they felt. But the MRI was clear. There was no compression on MRI. It was mentioned suggestive of posterior right paracentral herniation of C5, C6 interval disc with compression over the ventral aspect of the cervical dura thicca and right exiting nerve root. But there was on MRI there was no compression seen because all the roots foraminals are normal. When we went for EMG NCB, ENG and CV diagnosed as radial nerve palsy. So, as I said, always it has to match with your history and examination. So this is clinical radiological correlation. As a physiotherapist, we can do multiple things. I am working as a chief physiotherapist with my team of 13, and we are managing indoor and outdoor patients. Neuromonitorist, I work as a neuromonitoring also. I do the neuromonitoring. That is another a new field for physiotherapists. Nowadays, there are 4 or 5 physiotherapists in Ahmedabad who are practicing or who are helping the surgeon in surgery room OT. We work as a live EMG. We run the live EMG, and it decides whether there is compression or whether they are touching the nerve root or not. So that is a work of neuromonitorist. I work as a member secretary of SSHRI ethical committee. I'm working as a consultant physiotherapist in the body and the mind at the Gurudwara. So, as a physiotherapist, we have a lot of branch which is open. There are few who works as a fitness trainers. There are few who are working as a obesity trainers. There are few who are working as a dietitians. So, there is a benefit of our branch. Thank you very much. And this is my number. You can have it, and you can WhatsApp me if you have any queries. I can answer with that. Thank you. Shall we stop the presentation now? Okay, sir. करिए sir. Whenever you say, I'll be ready. સર આપણે રાખીએ સ્પાઇનલ અસેસમેન્ટ હિસ્ટ્રી ટેકિંગ એક્ઝામિનેશન અને ઓબ્ઝર્વેશન અને ડિફરન્શિયલ ડાયગ્નોસિસ. Okay. So you will be sharing the date. At present, I will not declare the date. This was the session about how to read the X-ray and MRI. I just took this first because I do not want to miss everybody to learn to read the X-ray and MRI. As a physiotherapist, we should be learning. We should be knowing this because one of our patients, one of the relatives, may need us, or maybe on occasion we need to take our stands. We need to stand on occasion against or with somebody to show that we know the reading of X-ray and MRI. But next, what I really feel to be taken is observations that what we practice when patient enters. We say, તમને તો મણકાનો વા છે ankylosing spondylitis. Then they will be happy. Yes. How do you know? So such observations, such examinations really help to diagnose or to complete the diagnosis. This was a small part of the diagnosis which I took, and the history part will be, I'm sure, will be more interesting. So me and sir will be deciding about the date when to keep it. Yes, sir, you can share now.
I would like to thank to the Birju sir for conducting nice session. We are also, next session already sir has conveyed that we will for the examination part, history taking, and we will conduct the next session for that particular. So we'll announce the date for that particular on our Facebook page, that is for the Ahmedabad Physiotherapy College. Kindly get that update of those particular, and we are also share this recording session for the part 1, so we can have you can all have an idea about the first session, so you can join the second session. Thank you all.